The broadcast is now starting. All attendees are in listen-only mode.
Okay, hello and welcome to the final webinar in our series on antibiotic stewardship, reporting and education of nursing home staff on antimicrobial use and outcomes. Before we get started, you'll receive an evaluation via email after the webinar, which you'll need to complete and return in order to receive your certificate. If you have any questions during the presentation, please submit them using the questions button so our presenters can answer them at the end. Now it's my pleasure to introduce Dr. Erin Epson from CDPH.
Great, thanks so much, Casey. It's hard to believe we're reached the end of this webinar series, and I'd really like to thank all of you with CAF and QCHF for partnering with us on this. Casey, can you advance my slide?
I just gave you control, so you should be able to do it.
Okay, I'm hovering over where, all right, there we go. Seems like every time we do the same thing. Just as a reminder, today is the last session. We're going to be hearing about education of nursing home staff on antimicrobial use and outcomes. And without further ado, I'd like to present or introduce the main presenter for this session, who's Bridget Olson. She's an infectious disease and antimicrobial stewardship pharmacist for Sharp Coronado Hospital. And Bridget is going to present on how to engage and educate frontline staff about stewardship. So with that, we'll turn it over to Bridget. Got your first slide up. Thank you very much, Bridget.
Hi, this is Bridget Olson, and I'm going to talk about long-term care stewardship, antibiotic stewardship, specifically on nursing staff training. I always use this picture on my first slide of my nursing staff training because I kind of always get a chuckle from the staff about it because it has an old style, old technology, and an old reporting. So I tell the nurses we've come a long way from this kind of reporting, and the purpose of the protocol that we've established is to provide the physician with more information so that he or she can make a better decision on whether antibiotics are indicated. My slide isn't advancing, Casey.
You got it, Bridget.
Okay, thanks. Why do we worry about over antibiotic use? 23,000 people are reportedly die from a direct result of antibiotic-resistant infections. And decades of overprescribing and antibiotic misuse have resulted in bacteria that are increasingly resistant, creating a new threat of multi-drug-resistant organisms called carbapenem-resistant Enterobacteriaceae, or CRE. Sorry, I'm having trouble getting on that right slide. So this, if I can, this slide shows the most commonly reported CRE is Klebpneumo, and the resistance for carbapenems has been below that of cephalosporins, aminoglycosides, and fluoroquinolones. And we've always had carbapenems to rely on, but now we're seeing resistance with those also. And if we lose the ability to treat Enterobacteriaceae, modern medicine isn't going to be what it is today. So there's two main factors that drive the spread of multi-drug resistant organisms. There's transmission between patients, which infection preventionists deal with, and then there's overuse and misuse of antibiotics, and that's the job of antibiotic stewardship. Now the CDC has identified that 20 to 50% of inpatient antibiotic use is either inappropriate or unnecessary, and that figure is up to 70% in long-term care facilities. So what are the issues that we deal with antibiotic stewardship in long-term care? Well, long-term care patients have many more comorbidities. They have more invasive devices and ever-advancing age. There's frequent bacterial colonization of infection sites, and there's often incomplete patient symptom reporting to physicians. Diagnosis and evaluation are extremely difficult for this population, and since physicians only have to visit the patients once a month, there's often antibiotic orders over the phone without patient assessments. Physicians might just assess culture results without looking at symptoms, and they're not sure of the best empiric treatment choices. There's also a lack of follow-up, and physicians tend to err on the more conservative side to be safe, and there's overuse of antibiotics, which results in antimicrobial resistance. So now we're going to talk about bacterial colonization. Bacteria can live on human skin surfaces and other sites without producing any signs or symptoms of infection. For example, 5 to 10% of the general population is colonized with MRSA, and 20% of kids are colonized with oropharyngeal strep group A. So if we treated every positive culture of a child and we cultured all the kids, we'd treat 20% of them unnecessarily because they wouldn't be infected. Inappropriate culturing of colonized sites may lead to unnecessary antibiotic exposure. Colonizations can persist for days to years, and they're influenced by the patient's immune response to the organism, competition from other organisms, and the use of antimicrobials. So we only want to culture sites that are suspected of active infection based on the patient's symptoms. If you look at the right side of the slide, you'll see 2 sputum cultures. And the top one has 1 gram-negative rod. It's from an acute care patient. And the bottom one is from one of our actual long-term care patient sputums. And you can see the entire plate is just covered with organisms, many different types, proteus swarming across. And it makes it very difficult for the lab to do dilutions for sensitivities on a culture that looks like this. Now, active infection occurs when a bacterial strain undergoes uncontrolled growth. The body will then mount a defense, and you may see for skin and soft tissue infections, redness, pain, pus, fever, or swelling. For respiratory infections, cough, increased purulent sputum, tachycardia, or tachypnea. And for UTI, you may see dysuria, changes in mental status, hypotension, rigors, or costovertebral pain. So the patient's clinical picture is the most important factor in determining whether the patient is colonized or infected. Now, long-term care patients have many of the risk factors for colonization: presence of catheters, trachs, vents, feeding tubes, prior antibiotic use, increased age, decreased stomach acid for GI prophylaxis, and immunocompromisation. And we never try to treat these colonized organisms because eradicating one may pave the way for the survival of another. And further antimicrobials may affect our beneficial organisms, such as in our GI tract. Antibiotics are also far less successful in eradicating the organism while it's in this carrier state as compared to a symptomatic patient. You've all heard of the McGeer criteria. These were published guidelines for identification of infection and surveillance in long-term care patients. The goal was to standardize the identifying factors for infections in long-term care patients that are often difficult to assess. Symptoms are not expressed or misinterpreted, or the comorbidities can obscure the signs and symptoms of infection. These criteria are divided into 4 main categories: UTI, respiratory, skin and soft tissue, and fever of unknown origin. So the way we deal with infections on our long-term care is we established a fever suspected infection protocol. And it's very multidisciplinary in our evaluation of the patients for initiation of antibiotics and reporting of symptoms to the physicians, and also in the empiric treatment and follow-up. We use comprehensive patient assessments that are in a checklist format based on the McGeer criteria. And this improves the evaluation for initiation for antimicrobials. We provide more information to the physician in that first phone call, including the assessments and labs and chest x-ray data. We put our order sets, we have ID recommended therapy and labs in our order sets, and that empiric therapy is defined based on our facility's microhistory and antibiotic sensitivities. We also have our pharmacists keep profiles on the patients that record their allergies, renal and hepatic function, history of resistant organisms, in addition to culture history and their symptoms. We educate all disciplines on the principles and goals of ASP, and so that they're aware of what we're looking for, what our purpose is, and what the workflow process is. It's important to develop criteria for initiating a workup for infection. Now I'm going to show you what we developed, and you can use this or you can develop your own, but it's important to develop, have 2 instances of either fever and or new change in vital signs showing patient distress. And the key word is new. So the fever point we use is 100.4 or 38 degrees centigrade, and this is a little bit higher than the latest McGear criteria of 100, but this is what our ID physician chose. And our vital sign parameters are heart rate greater than 100, systolic blood pressure less than 100, O2 sat less than 94%, and or respiratory rate greater than 25. And we have to caution the nurses that if a patient has AFib, he or she may have a heart rate greater than 100 normally, so you want to look at points higher than that. So then after the first abnormality is detected, the patient should be repositioned, suctioned thoroughly, and cooling measures applied. And if the fever or change in vital signs still exist after at least an hour, then the RN is to initiate that first infection workup order set that provides CBC, electrolytes, and chest X-ray. It's important not to treat just isolated fevers, and that's why this population can get. That's why we use the 2 instances. The suctioning can also clear any mucus plugs that the patient may have. And sometimes the families may bundle the patients up, and they might be in persistent vegetative state, and they can't remove the covers, and they get overheated. So there's lots of things that can happen in this population. Okay, so this is our power plan. We're computerized, so we have it all built in for the nurse to just initiate. Everything's pre-checked. This little check right here, we have this on the admission power plan that the physician signs so that to allow for the use of this protocol. So we have our patient status with the parameters that they're looking for to initiate it. We have the repositioning, the suctioning, the labs, and the chest X-ray, and then it also shoots a consult to us in pharmacy so that we know the patient's being evaluated for antibiotic initiation. We also have a box checked for the respiratory therapist, and the RN can uncheck that box if there are no respiratory symptoms. Let's see if that's going. Now, nursing assessments are one of the most important things to educate on. Somehow I'm not going to the next slide. Sorry about that. Can you guys advance the slide for me?
There you go.
So the importance of nursing assessment is huge. The nurses are the eyes and ears for the physicians, and it's based on their assessments. Sorry. Based on their assessments and their reporting of their assessments that determines whether the patient's going to be ordered antibiotics. We have them do the assessment either between the fevers or the period that they're waiting, depending on how stable the patient is, or while they're waiting for the labs and chest X-ray. The patient assessment form looks like this. And the shaded area, I tell the nurses, is the most important. It has 4 boxes for the 4 main categories of the McGear criteria and the symptoms that are associated with each. So I have them run their eye down here and check off anything that applies, because with this population it's often very difficult to tell where the site of infection is. So if you check off all the symptoms, it kind of gives you a better idea of what you're dealing with. We also have them report patient status, their transfer status, their treatment status, and vitals. I encourage them to review and discuss with another RN or clinician. It just helps to bounce it off with someone, especially if that person knows the patient. And the nurse's subjective opinion is very, very important. I had a nurse call me and say, my patient has had the 2 fevers above 100.4, and we're waiting for the labs. We've initiated the protocol, but he's just laying there smiling. And so sure enough, when we got the CBC back, the white blood cells were like 6, and the patient had no symptoms and did not require any treatment. Another time, the nurse said the patient has a fever of 100.6, which is above the mark, but I don't want to wait for the second fever because she looks really bad. And so we listened to that. We got ready. We figured out what we were going to need based on her microhistory. We called the physician, and by the time we were getting the antibiotics going in, her fever was up to 103, and we later found ESBL E. coli in her blood. But everything turned out all right because we expedited the treatment. Our pharmacists also keep Excel profiles on all the patients that keeps their history of all their morbidities, their renal and hepatic function, their allergies, and what they've grown and been treated with before. So that helps to have them involved as well. Now the second power plan we use is called the IV Fluid Challenge, and this is at a convenience for both doctor and nurse so that they don't have to spell all this out and everything can be just ordered with one click, especially when the physician is called at 2 in the morning. And isn't familiar with the patient, maybe on call for another physician. And so if the patient's having hypotension or tachycardia, you can just order IV Fluid Challenge per protocol, and the volumes are small to allow for CHF or decreased renal function. And if the physician knows the patient, he or she can order higher volumes. So now we're going to talk about empiric versus targeted antibiotic therapy. Empiric antibiotics are the initial antibiotics that are used prior to knowing the type of organism that is in the suspected infection site. The culture results of the organisms from our facility and in combination with the antibiotic biogram sensitivity data give clinicians an idea of which antibiotics should be ordered for their patients. Initial empiric choices should offer broad spectrum coverage to cover the organisms that could be growing and to give the patient the best chance of recovery. And then after the culture results are available, usually 48 to 72 hours, antibiotics should be reviewed by the ASP team to recommend a more streamlined or targeted therapy, ideally only affecting the organism that was cultured. Now this is an example of our antibiogram, and over here you have the organisms, over here the antibiotics, and these numbers are the percent that are covered by the respective antibiotic for that organism. And then these are gram-negatives and these are gram-positive. Your lab can run this for you if you request it, and it's important to have it specific for your facility. We also have our lab run reports of cultures of the different infection sites so we can see what proportion of organisms we have on each site. So these were from our facility for the year 2015. For the respiratory organisms, we had 54% Pseudomonas, and so we know we need to cover Pseudomonas empirically. And the cefepime we choose will cover most of these organisms except for the MRSA. So because MRSA pneumonia can land a patient in the ICU, we usually cover empirically with doxycycline. Now for urinary tract infections, if you saw a graph like this from acute care or the community, it would have E. coli as your predominant causative organism. But for us, our most predominant organism is Proteus. But we don't have many resistance problems with Proteus. It's E. coli we have a lot of issues with 46% of ours MDRO. So we use gentamicin, and gentamicin has covered all our ESBLs for the last 2 years. So it's a good choice for our facility. It may not be for yours, but that's why you need your own specific micro reports. And then when we look at the blood, what patients have become bacteremic, we see E. coli again and no Proteus. So we target our empiric therapy towards E. coli. It seems to be more pathogenic at our facility. So to determine your appropriate antibiotic, empiric antibiotic choices, you want to provide your antibiogram sensitivity data and your culture report data of the organisms grown in your site to your ID physician or ASP physician, whoever is helping you. And they can determine the ideal empiric antibiotic choices for your specific site in the different infection sites. And in IV and PO and feeding tube options should be provided, including options for severe penicillin allergy, and then other options should be considered for patients that are colonized with multi-drug resistant organisms. Now, we maintain a list of patients that have these organisms for the pharmacists that occasionally get called at night, so they know what to use. Now, this is an example of our empiric treatment ID recommended therapy, just for UTI and respiratory. It's just a snapshot. So we have for UTI our GENT, it tells how to load, and then our PO option for cystitis is cefuroxime is our best choice. For respiratory infections, there's our cefepime and doxy, and then we also point out that we can do IM therapy if we can't get the IV access, and then we don't require the nurse to call the physician back, so that eliminates another phone call, especially during the night. So we have probiotics automatically added per our protocol. We use a 3-species lactobacillus combination for patients that take oral, and then we use liquid probiotic yogurt for patients that have feeding tubes. We continue for 1 week past the antibiotic course. For skin and soft tissue infections, we built this treatment algorithm, which we embedded in that power plan. And we used to use Vanco and Rocephin on everybody for all the cellulitises. And then we divided the therapy now into purulent versus non-purulent therapy, because purulent therapy is aimed at staph, non-purulent at strep, and we usually never get past the mild cellulitis because the nurses are always really on top of things. Okay, so this is an example of our ID recommended cultures, and we have everything all pre-checked. This is for the patients that it's just really hard to tell where the infection is coming from. But sometimes you're lucky and it's obvious. Like if it's respiratory, you want to make sure you have that MRSA molecular amp of the NAIRS, because it's closely correlated with MRSA pneumonia, especially as a negative predictive value. And then, so you can uncheck that if you're sure it's urine, and you can uncheck urine if you're sure it's respiratory. We never get cultures until we've made that decision to treat because of the colonization issue. So urinary tract infections, many patients are colonized, especially those with catheters. And in long-term care facilities, the UA is really only useful if it's negative, because patients may show chronic bacteriuria or pyuria with or without infection. Fever and or leukocytosis, white blood cells greater than 14,000, usually indicates higher involvement, such as pyelonephritis, bacteremia, or the need to rule out sepsis. The catheter should be changed prior to the culture, if not changed within the last 14 days. And hypotension and or changes in mental status are more associated with UTIs than other infections. And so the patient's clinical picture must be used to diagnose a UTI. We took the McGeer criteria and we made it into a flow chart for easy reference. So we have the catheter arm and the no catheter arm. And then we have the constitutional criteria here that has the fever, leukocytosis, and changes in mental status. Over here, if you have no fever or leukocytosis, so that would be the cystitis. It has the symptoms that are required. You need 2 of these. And then we have change in mental status plus change in urine. and dysuria or fever or leukocytosis, then you need one of these symptoms. For catheter, it's a lot easier to qualify for antibiotics. So these forms are available from the CDPH website. Respiratory tract infections have risk factors of aspiration, sedative medications, and certain comorbidities. We do prevention strategies with our vaccinations for strep pneumo and influenza. And then the chest x-ray can help differentiate between many different types of respiratory syndromes, not all of which are infectious. Patients should be suctioned and repositioned, otherwise known as the pulmonary toilet, by nursing or respiratory therapists to remove possible mucus plugs. Many patients are colonized, especially those with vents or trachs, and leukocytosis greater than 14,000 may indicate a need for antibiotic treatment. Heart rate greater than 100 and or respiratory rate greater than 25 are often associated with respiratory tract infections since they show distress. And then we use changes in the amount or purulence of the secretions to evaluate for initiation and to monitor for response to therapy. Okay, so we also made a McGear flowchart for respiratory tract infections. It has two arms, a pneumonia arm and a non-pneumonia arm. For non-pneumonia, you have the negative chest x-ray, then you need at least two of these respiratory sub-criteria. These are just specific symptoms. And then one of the constitutional criteria, so either fever or leukocytosis or changes in mental or functional status. If you have the pneumonia, you need just one of the constitutional and one of the respiratory sub-criteria along with the positive chest x-ray. So now we're going to talk about C. diff and our initiatives for reduction. In addition to antibiotic stewardship and controlling the use of antimicrobials, which is very, very important, we also made a big change in the intensity of our GI prophylaxis. So in 2010, we took all our patients that were on PPIs for GI prophylaxis and we changed them over to H2 antagonists. And then we do that now upon admission. And my nurses are so good, they ask the physician right when they're going over the initial orders. So we hardly ever even have to do it. And this has had a tremendous impact on our rates. We also initiate probiotic therapy. We have this automatic as part of our protocol with all antibiotic courses plus one additional week past the course. And that helps to replace the good bacteria that the antibiotics destroy. And this was the result of those three initiatives. We used to have between 15 and 20 cases per quarter when we first started monitoring. And now this year, 2016, we've had only 4 cases for the total of acute and long-term care. We made all those initiatives we rolled out between 2009 and 2010. So you can see how the rate has stayed low ever since those were rolled out. We also track our days of antimicrobial therapy through, we call it DOT, which is days of therapy per 1,000 patient days. So it's not dependent on your census. It's really good to get this baseline before you start your antibiotic stewardship because you can trend your success. And we were on a steep upward climb with ESBLs becoming very popular among our patients, and so we started doing our interventions and monitoring at this point, and then we didn't have any outside admissions here of all these long antibiotic courses, so our use went down. But then we started our fever protocol right here, and just this 2-year period right here, we had a 40% drop in overall antibiotic use. So now we're going to go over some case examples. The first one is always everyone's favorite, but it's a night shift fever, temperature of 102, but all your other vital signs are stable on this patient. So the nurse goes in, repositions, uncovers, suctions, and does a complete patient assessment, doesn't find any mental status changes, no changes in tracheal secretions or cough, no pain, no distress, no changes in urine, no skin issues, and the vitals remain stable. Even after the recheck, the temperature comes back at 98.9. So no initiation of the infection workup, no call to the physician, since there's no second fever and the vital signs remain stable. So the nurse faxes the assessment form to pharmacy because we track these patients so we can see how often this is happening, and we found that in about 20% of the fevers, they never get a second one. So right there, we're cutting down on antibiotic use, calls to physicians, and everybody's happy. So the second one, we've got a temperature of 100.5, but the rest of the vitals are stable. The RN goes in and does her thing, and then the recheck after an hour, the temperature now is 100.8, the heart rate's up to 88, but look at the blood pressure, down from 120 systolic to 92. Now this 92 may be normal for some patients, and you always need to take that into account. I've had a physician tell me that she had a patient that was normally in the 80s. And so you always need to know what's normal for your different patients. But this drop in an hour is very significant. So the criteria are met with the change in vital signs, and the fever was above the mark, so you have 2 fevers also. So the infection workup order set is initiated, and then the complete assessment is done, and the nurse finds the patient now is not arousable. She's diaphoretic, the urine's cloudy and foul, but there's no cough or change in tracheal secretions, no skin issues, and the patient has a suprapubic catheter unknown when it was last changed. So the lab results come back with white blood cells 16.8, and everything else is normal. So the RN calls the pharmacist on call, and that's the way we do it. We just have the pharmacist give the recommendation at night, and the pharmacist is called when the white blood cells are greater than 14 or the patient's status dictates. So then the pharmacist reviews the McGear criteria charts and the list of patients with resistant organisms and recommends gentamicin for UTI, as it looks like the patient is qualifying for UTI. Then the RN calls the patient and reports in an SBAR format, and that's where you tell the imminent situation first. So he or she would report the decrease in blood pressure, the elevated white blood cells, and the fevers, and then give a brief background. It's really helpful if the RN has someone helping him or her to tell if the patient has a history of CHF or decreased renal function, because then the physician can order a higher volume of fluids without concern. Now the assessment would be whether they're meeting criteria for antibiotic initiation, and then the recommendation would be the fluid challenge order set because of the hypotension, the cultures, and the gentamicin as per the pharmacist recommendation. So the patient stabilizes after the fluid challenge with a normal BP, and appropriate antibiotics are started. The pharmacist comes in the next day, reviews with the RN to make sure the patient, check on the patient's status, and no further call to the physician is warranted, but then the primary physician should be notified if he or she was not on call that night. Then the ASP will follow up for streamlining of therapy and appropriateness. So our last case, also the patient has a fever, but it's only low grade, 100.2, but we have some change in vital signs with the heart rate of 110, respiratory rate 26. So the nurse does her thing, repositioning, uncovering, suctioning, and the vital recheck comes back with still not a fever above the mark, but now the heart rate's 125, respiratory rate is 32, and O2 sat is 91%. So the criteria have been met in several ways with the vital signs. So the infection workup order set is initiated, and the assessment is done. So the only unusual thing the nurse finds are new copious purulent tracheal secretions, and the patient is on a ventilator. Lab results come back with white blood cells 18.5 and a possible new infiltrate. So the patient assessment is faxed to pharmacy, and the pharmacist notes the consult. This is during the daytime. Pharmacist reviews the labs and patient history, and then we have either the pharmacist or the nurse calls. It depends on if the patient has resistant organisms, then they usually like to talk it out with the physician. But they do the same situation, background, assessment, and recommendation. And so here they're ordering the cultures per power plan, and they decide to omit the urine culture or UA. We caution with that because sometimes you think it's respiratory, and then the pulmonologist comes in and says, it's not respiratory, where's the urine? So you, if there's any doubt, you should get the cultures from both sites. And then, so appropriate antibiotic therapy is initiated, and the ASP will follow up for streamlining. So our key points are that you want patient assessments, and then if you have labs and x-rays and the RN's subjective opinion, you want all that to be reported to the physician, and ideally in an SVAR format. You also need 2 fevers greater than 38 or new changes in vital signs to initiate the workup. You want to avoid treating isolated fevers that can happen in this population. Sorry, my screen is not showing everything. And the third point would be that positive cultures are not indicative of infections. They can be, patients can be colonized. And antimicrobial stewardship is always a multidisciplinary team approach. So looking at our timeline, we spent a lot of time developing our workflow and our guidelines and order sets. We spent a lot of time doing education. That was really, really important. And then we did, what resulted was tremendously improved communication and reporting of patient assessments. We started treating only infections, not colonizations. We had appropriate empiric therapy and great multidisciplinary function. And then the last couple of years, we've been able to show not only improved antibiotic use and patient care, but also decreased antimicrobial resistance. We've had decreased resistance for Pseudomonas, E. coli, Club pneumo, and of course our C. diff rates have gone way down. So in summary, be sure and define your challenges, know what's holding you up, and ask for help. It's good to train a few RN experts for others to consult, and the ones that deal with it more, have them work on the ones that haven't. And remember that you're not going to achieve success overnight. Be sure and get baselines and track your improvement. It's motivating. And if you have any questions, feel free to give me, shoot me an email, and I'd be happy to help.
Thank you so much, Bridget. That was terrific, and those tools are all extremely helpful. And as I think you mentioned, we've got several of them posted on our website, and I'll be showing in a moment where participants can find those. We'll do a little bit of Q&A now with Bridget. And Casey, are there any questions already entered in the webinar?
Well, it looks like we have one question that says, can we print slides, which I can answer. Yes, we sent out materials last night and again just before the webinar started. Should have a PDF copy of all the slides in Bridget's presentation, and I can go ahead and resend the PDF out again. If anybody needs it, just go ahead and enter your email and request the slides in the question section here, and I can get those out to you after the presentation.
Great, thank you. Yeah, and I'll also mention as well that the recording of the webinar is also going to be posted on our website too. Just maybe while we're waiting, if there's any other for any other questions to queue up on the webinar, Bridget, I'm wondering, how frequently do you give this in service to the nursing staff?
I do it as part of the nursing annual competencies, and there's always so many new nurses, so I try to catch as many as I can there, but I do a briefer one with every new nurse that comes on board, and it's part of their checklist of everything that they need to go over when they're a new employee. But and then I go over updates with them on an annual basis, like when we change things based on the annual micro reports.
Ah, great. Thank you.
Okay. Looks like we do have a question in. Is reporting to pharmacy applicable in California?
Well, our physicians ask that we be involved as pharmacists because it's so much for nursing to handle. We didn't have them contacting pharmacy at first. The first 2 years we had it, we just had the nurses handle everything, and it was just a little too much. And it's like the more help you have, the more multidisciplinary it is, we found, the better it works. I don't know if there's anything specific about California. I think we just did it because it worked for us. And we have pharmacists on call for the acute care hospital, so they take call for the long-term care also.
Great. Okay, and we have a couple more questions here. The first one, how do you utilize the McGear's criteria when a patient is vent-trach dependent for respiratory infection?
Yeah, I mean, when they're in persistent vegetative states, or like the situation that you describe, it is more difficult, and that's why I've told the nurses that it's really important that we track the secretions, and so talking with them about what's normal for the patient and the changes that they see may be very, very subtle. It may be just the way the patient looks, it may be that they're experiencing pain, or just their change in vital signs. So it can be challenging in some situations. I can confirm that.
Great, and let's see. Another question, how often should we update our antibiogram for ASP? How far back should we go with our antibiogram?
Well, we do ours annually. If you can get back years, that would be great, because it's nice to see trends that happen. Like you can see if your ESBLs have been going up for the last 5 years. But annually is sufficient.
Okay.
So do we have one more question we can do before we move on to the rest of the webinar?
Okay. Well, this will have to be the last question then. Title 22 states no standing orders can be used in long-term care. How does this differ from protocol orders?
Okay, that's why it's not a true protocol, in that we do have the physicians okay it with the order on the admission order set. And so they're basically okaying the use of it for that initial workup power plan that's initiated before they're called. And since we have that, they're okaying that, then we're able to use it. That's a good question.
Yeah, that's a really helpful clarification. Casey, shall we, can we move to the next slide? And thank you very much, Bridget. And Casey, please let me know if there are additional questions that were entered in the webinar that we might follow up on afterwards.
Sounds good.
But we've got a little bit more left for you all participants. So let's see, am I able to advance to the next slide?
You should be able to, yes.
Okay. Always a challenge, no matter how frequently we practice this. I'm trying to get the, there we go. All right. Well, I just wanted, by way of a recap, to remind everyone, the topics and information presented over the course of this series were adapted from CDC's core elements of antimicrobial stewardship, and they're outlined here on this slide in a checklist format. And just, as we conclude our series, looking ahead to the requirement that will be in place as of next month, I just encourage all of you to look over this checklist and gauge your progress. And just in doing so, I think it's important to recognize CDC's guidelines recommend taking a stepwise approach. So 1 to 2 activities to start, gradually adding more strategies from each element over time. And then just also recognize that this is quite as much about reinventing the wheel as it may at first seem. And for many homes, one of the messages that we've conveyed during the course of this series, stewardship might really, at least in part, be a matter of incorporating, enhancing some of the existing activities that you're doing, and then just doing them with a greater intention towards stewardship. And so the core elements document that CDC provided can be accessed by following this link here on the bottom of the slide. And just in the interest of time, I'm not going to go through each element, but would really encourage all of our participants to review this. And then I mentioned, we've compiled links both to this CDC checklist as well as some other stewardship guidelines and resources on our program's website. And so I just wanted to briefly point out where you can find these. So our program's web address is listed at the top of the slide. That's for our sort of general healthcare-associated infections, or HAI program website, and you can follow the links to the California Antimicrobial Stewardship Program Initiative. And this is just a screenshot of that landing page for the Stewardship Program Initiative. And then I've got, I'm just sort of highlighting with an arrow here some of the resources that we've put together for skilled nursing facilities. And the first is this Antibiotic Stewardship in Nursing Homes webinar series. This is where you can access all of our webinar recordings and examples of implementation. I'll show those in just a second. The other resource I just wanted to highlight real quickly is just that CDC's core elements recommends nursing homes establish access to individuals with antibiotic expertise, and this could include partnering with the stewardship leads at hospitals within their referral network. I think we kind of talked about this a little bit at the end of the most recent last webinar. And so I just wanted to point you all to this Spotlight on ASP project, and that's you can access by where that second arrow is. And this Spotlight project, we've actually recruited hospital-based stewardship leads to highlight their program's activities and then publicly share their information on our website. And currently, we've had about 80 different antimicrobial stewardship programs that represent almost 100 hospitals throughout the state join this. And so if you're a nursing home looking to find, identify some mentorship or consultative support in your geographic area, check out our Spotlight on ASP project, and you can access it on this web page. And then here is just the webinar series and examples of implementation page that you can access. And this is where we have all of the webinar recordings as well as the implementation examples, including several of those that Bridget has graciously shared with us, and which she presented during her presentation just now. And if there are additional tools that we haven't included here, we can certainly see about adding those. And so, with that, we have for the last several minutes of today's session, Deborah Brown, who is a pharmaceutical consultant with our CDPH licensing and certification program, joining us. And Deborah is going to briefly discuss survey implications for demonstrating compliance with Senate Bill 361. And then she'll be available for any questions you might have for her as well. And so thank you so much, Deborah, for joining us today.
And thank you, Erin, for providing me with this last opportunity to present on this topic. Is my first slide up? My first
yes.
slide demonstrating? Okay,
now.
Thank you. Okay, so I'm sort of at a disadvantage because I don't have a computer, so thank you for advancing the slides for me. First, I would like to review general compliance with SB 361. And as you know, the statute actually adds Health and Safety Code 1275, Section 1275.4 to our licensing requirements. And basically, it indicates that skilled nursing facilities shall adopt and implement antimicrobial stewardship policy by January 1st of 2017, and it should be consistent with guidelines developed by the CDC, CMS, Society for Healthcare Epidemiology of America, which is SHEA, or similar recognized organizations. And just as a reminder, last year the department issued AFL 15-30, which advised skilled nursing facilities of the chaptered statute, and also offered resources, and one of those specifically was our own HAI unit, and it's certainly over the last year, I think that that our unit, the HAI unit, has worked really hard at trying to collect resources that are specific to skilled nursing facilities. But it's also a great resource for other types of guidance that would help you implement your antibiotic stewardship program. So simply put, the required components for a skilled nursing facility to be in compliance with this statute are adoption and implementation of an antimicrobial stewardship policy by January 1st, as I indicated, and ensuring the policy is consistent with guidelines developed by CMS, SHEA, or similar recognized organizations, such as CDC. And as long as providers have fulfilled the required components, they are in compliance with the statute. And could you forward to the next slide?
Certainly.
So more specifically, in order to determine compliance with Health and Safety Code Section 1275.4, state evaluators will utilize our usual investigative processes common to all surveys, and that would be observation, interview, and record review. As you know, everybody's aware that as soon as we begin our survey, we start doing infection control observations. This is the way we've always done it. In addition, we will be, looking at more elements of your antibiotic stewardship program. So some of the things we already look at are hand washing and isolation practices. Those are some of our observations. There are a variety of people we always interview during surveys, and this will continue, licensed and non-licensed staff, to find out what the policies should be implemented. Designated infection control professional that's on your staff, and also the activities that have already been implemented that are related to antibiotic stewardship in conjunction with your policy. We also interview, of course, administrative staff, clinicians, and prescribers to again, evaluate adherence with facility policies. With regard to record review, we look at, of course, resident records. We're going to look at treatment protocols that have been ordered by physicians, facility policies and procedures, and as well as employee training records to find out what kind of education process has been going on with regard to antibiotic stewardship and infection control. And the last slide.
There you go.
So, okay, thank you. So I think everybody's aware by now that CMS published the long-term care mega rule in the Federal Register on October 4th of this year. And it includes revisions to FTAG 441, which is the infection control tag. And I think everybody's also aware there's going to be a phased-in approach to compliance. And CMS did that so that, because there were some aspects of this implementation that required more resources, and so CMS made a decision to phase in the requirements. Currently, and this is part of phase one, we currently will be evaluating the infection prevention program and control program, and this is the way it's always been, so nothing's really different about this. However, phase two, which begins next year on November 28th of 2017, there needs to be an implementation of an antibiotic stewardship program. So I think in California, facilities are going to be ahead of the curve because they already have this requirement in place in January, and will be well prepared to demonstrate federal compliance as well. And then the third year, phase three, which begins in November 28th of 2019, there's going to be a requirement to have a dedicated infection control program officer, and that person will also be required to participate on the QAA committee. And this is probably, from a resource standpoint, this is probably the biggest aspect of this. And so the compliance will be staggered, and surveyors will not survey to those phase two or phase three requirements until the dates that I indicated. And that completes my part of the presentation.
Thank you so much, Deborah. So I guess in the remaining few minutes, if any of the participants have a question for Deborah, please go ahead and enter that in through the webinar. And Casey, have we received any questions for Deborah?
Let me take a look here. The last question we have says, we have family involved in order that ATB, she called doctor herself and asked ATB, educated the family, but still an MD reaction was whatever the wife wants to give the resident. I'm sorry, can't exactly follow that one.
Well, go ahead.
Oh, go ahead. No, that's fine. You go ahead. Because I think you would probably respond the way I will.
Oh, well, I mean, and I was actually also going to, ask if, Bridget had any, thoughts on this. And I mean, I think this just sort of highlights, the importance of the education piece and making sure that, patient, and families are also included in the education process. And also would just want to mention that, I think we heard during one of the earlier sessions, about the importance of engaging the ombudsman as well in antimicrobial stewardship practices within the facility, such that they can, kind of help with some of that, resolving of concerns and potential disagreement about appropriateness of antibiotic prescribing. But, Deborah or Bridget, please feel free to comment as well.
Yeah, well, with the new requirements for TJC on patient education and families, that's why that's so important. And so, I mean, fortunately, we haven't had to deal that much with families requesting antibiotics when they weren't appropriate, but it has come up. And we just, I have to go over there and talk to them, and they actually will listen to a pharmacist a little bit more, I think. Maybe it's just having someone else tell them, but it's a difficult situation sometimes.
And this is Deborah, and I completely agree. I think the education component is really important, and I think what families kind of get conditioned that, there's like a knee-jerk response that when there's a suggestion of a symptom, maybe of a UTI or something, and that person has a history of recurrent UTIs, that the antibiotic gets started right away. And I think it's going to take a lot of sensitivity and diplomacy to work with the families and help them understand. And from the physician standpoint, in terms of saying do whatever the family wants, I think there's an opportunity to also educate physicians that this is, that we've, made some changes in the facility in provision of antibiotics and antibiotic stewardship, and I think it's important to get all the physicians on board as well, so that they understand that the only way this is going to be implemented correctly is if everybody plays their part in an interdisciplinary way for the ultimately better care of the resident.
Great, thank you. And since we're at the top of the hour again, Casey, is there one more question we could address before we finish?
Yeah, we have a few more questions, but for a final one, I think this is a good one. Are there any required educations at this time that for infection preventionists that CDPH is looking at?
We, we don't have anything specific at this point that we're requiring. I'm not sure, how that's going to flesh out once the federal requirements go into effect in terms of the type of education professionals have gotten in the facility in order to fulfill this role. But what we will be looking at is just to make sure that that person has some training and expertise to be able to guide the facility in their antibiotic stewardship program. Okay,
great. Well, thanks everyone for joining us. Thank you to Erin and Bridget and Deborah for wonderful presentations today. And I guess this will conclude the webinar.
Yes, many thank you to all of you, and and please feel free to reach out to us at this website here, or this web email address here, the HAI program at cdph.ca.gov. Let us know what else would be helpful in your efforts. And so thanks everyone for joining us for this series, and really greatly appreciate the partnership with with CAP and QCAHS in putting this on.
Okay.